Hi, my name is Rick Wiggins. I'm a radiologist at the University of Utah. For those not familiar with the United States, I'm in the Wild West. Thank you very much for letting me come and talk to you. I would much rather be there in person. Hopefully I can make it over there in the future, but we'll have to make do with this for the time being. I'm going to talk about NI-RADS, the ACR neck imaging reporting and data systems that we use to talk about complex head and neck cases. So you already heard about some of the other RADS systems. I'm going to specifically be talking about NI-RADS in this lecture. So I was a member of the ACR NI-RADS committee. I have nothing significant to disclose, but I have spent a lot of time thinking about this and talking about it and thinking about kind of what the good and bad features, what things I liked and what I didn't like about the NI-RADS system. So we'll talk about what is NI-RADS and talk about the staging system and discuss how to use it. And there's a lot of information you can get on the ACR website about all of these reporting and data systems, including the NI-RADS system there. Now, I like to think about this as kind of like a stoplight. Do I see nothing? Do I see something a little bit suspicious, or do I see definite disease in that area? So for us, green, yellow, and red in that sense. So I'm going to talk about NI-RADS in kind of simplistic terms: what, who, when, how, and why. So what is NI-RADS? Who are the NI-RADS patients? When do we use NI-RADS? How do we use it? And why we should use NI-RADS itself. So I'm going to start off with what is NI-RADS. So you've already heard about some of the ACR RADS, the reporting and data systems, but these are all systems to provide a standardized framework for reporting on imaging studies. And the goal here is to reduce variability in terminology in our reports and to ease communication. That totally makes sense. Terminology is a big deal for us. A lot of people use different words for different things, and the speech recognition systems and templates are something that people love to argue about in our world. So most radiologists include some kind of standardized terminology, but this varies a lot depending on different locations and sites, especially internationally, when we think about different pathologies and modalities and techniques and everything else, as well as recommendations for data collection in your reports. And the idea is that with the RADS systems, that can help with these statistics. If we have a good data collection system, we can include recommendations for these complex patients. And generally, those RADS are modality dependent, but I think they can be used independent of modality and independent of pathology. The RADS are developed by committees for the American College of Radiology, the ACR. Those committees work to build the structured terminology. A couple of different groups have gone through this, like the RSNA RADLEX, to try to get people to use certain words. A lot of people like that, and a lot of people don't like it. The risk assessments that we talk about do make sense, though. Sometimes you look at a study, and this is how we work with everything. This is normal, this is probably benign, or I think this is kind of definitely malignant, or this is definitely pathology at this location. So the idea with all these tools of the ACR RADS system is to provide the lexicon and kind of an atlas and flashcards and white papers to explain this, to try to standardize that care. So what is NI-RADS? So NI-RADS is specifically neck imaging. This is a risk stratification system and a template, but it's specifically set up and used for head and neck cancer surveillance imaging, not just any pathology. I kind of think that we should be able to use this kind of for everything, not just cancer surveillance and not just for squamous cell carcinoma. And again, you can find a lot of that information on the ACR website, acr.org. The idea here is that this was developed for post-treatment head and neck imaging surveillance, initially just with squames. And the general idea was that we would model this after the BI-RADS system. The aims here are to provide numerical levels of suspicion to guide patient care, standardize the approach with linked management recommendations, and generate data mineable reports. It's always nice when our reports are something that's more easily searchable, and you can think about QI, QA, and QC work, quality assurance and work in that sense, and to highlight radiologist added value in patient care. So in some ways, everything that we do on imaging, whether it's CT, MRI, plain film, ultrasound, nukes, anything, we can think about it very simplistically like this. And this is what most of my day is like. I don't see anything on the study that's green. You know, I see something, but I'm not very suspicious. I think it's nothing. That's kind of yellow. I have a high suspicion in some cases. That's kind of orange. And sometimes I look at things and I think this is definitely disease. This is definitely pathology. And that's red for us. So it's kind of an elongated stoplight adding orange in that sense for these 4 levels. And the NI-RADS system is kind of set up like this. And we published a white paper on this in 2018 discussing the ACR committee and the imaging reporting and data systems that was conceived with the NI-RADS system that we had initially started meeting and discussing in 2015 and 2016. So in 2016 was when the ACR formally convened the neck imaging reporting and data systems, the NI-RADS committee, with those goals. Now, if we think about this simplistically, we could think about green, no evidence of disease, yellow, low suspicion, orange is kind of high suspicion, and red is there's definitely disease in this case. Now, this totally makes sense to me, and that's how my entire job over the past 20 years or so, 20 or 25 years, has been with studies. I think this is normal. I see something, but I'm not very suspicious. I see something and I am suspicious, or this is definitely disease. This guy's got an SGO. There's something going on in that case. That's how I think about things all the time. Now, specifically for NI-RADS, it was set up just for recurrence and only in squamous cell carcinoma. So there are some limitations, obviously, to this NI-RAD system in that sense. So 1, no evidence of recurrence, 2, low suspicion, 3, high suspicion, and 4, definitely recurrence. So specifically on imaging, if you have a nuke study, low suspicion, we have kind of ill-defined soft tissue with mild to moderate FDG uptake. High suspicion, there's discrete new or enlarging soft tissue with intense FDG uptake. And category 4, definite recurrence, either pathology, clinical, or radiologically definite progression of disease, definite recurrence. Now, level 2 was actually divided up into 2 different groups, superficial and deep. And this reminds us that I, as a head and neck radiology, I am not a mucosal surface doctor. That's not my world. I don't do cross-sectional imaging a lot of mucosal surface lesions, just like skin rashes. I don't do CTs for seborrheic keratosis. That's not my job. So if I see something that's superficial and suspicious, I'm just going to tell my head and neck surgeons, somebody needs to go in and look at this. He needs direct visualization. Now, if it's deep, we're going to think about short-term follow-up or getting a PET CT if we don't already have one to try to evaluate that area. So those are the 2 divisions of category 2, the low suspicion group. So level 2 was divided into superficial and deep. And we have recommendations for all of these. So for level category 1, those guys are just going to get routine follow-up. For category 2, again, there's a division, 2A and 2B. 2A is that superficial. If I see something superficial to look at, I just tell my surgeon, somebody needs to go look at this. Now, if something's deep, I don't think it's along the mucosal surface, that's a 2B. Those patients are going to get short-term follow-up and or PET CT if I don't already have one. Now, if I see something I'm more suspicious of, highly suspicious, I'm going to say this guy needs a needle. We need to go biopsy this lesion. And if it's category 4, definite disease, whatever the clinical care is for disease at that location and the size, that's going to be our recommendation. So we have staging and we have recommendations that are all based on this green, yellow, orange, red system that we have there. Now we also have a template. We mentioned verbiage and the words that we use. So if you think about a templated report, if you're in the structural reporting world, we try to think about that, and we have one with the NI-RADS system. So if we try to make the findings that are succinct and efficiently reported, saving time for the radiologist, and in the impression, we give one staging for the primary site and one for the neck, for lymph nodes. So we're going to have those 1, 2, 3, 4 staging for the primary site, and we're going to have 1, 2, 3, 4 staging for the neck nodes. And they may be managed separately in that sense. Now, depending on your shop and how you work up these patients, most head and neck cancer patients, if you're not doing whole body PET CT, you should probably be doing at least a CT of the chest, because somewhere around 10% of patients with head and neck squamous cell carcinoma already have distant metastatic disease when they present. So depending on how you're working up your patient, you can also include distant disease in this discussion. So an example of a template for NI-RADS might be here. Whatever the indication is, do I know the HPV status of the patient? Have they already had surgery, chemo, radiation, all three, none of the above? The technique and the comparison, generic discussion of findings. So again, in the impression, we're going to talk about the primary and we're going to talk about the neck. So we're going to try to give a NI-RADS category 1 for the primary and a NI-RADS category 1, category stage 1, 2, 3, 4 for the lymph nodes, both. Now we can also include a legend at the bottom. So if people are not familiar with the NI-RADS system, we can include a little legend to explain those 4 levels for each one. This allows interpretation by any clinician, hopefully decreasing our phone calls and follow-ups with people to understand what the NI-RADS system is. So just as an example of a legend, so if we were to put this at the bottom of every NI-RADS templated report, 1, 2, 3, 4 for the primary and 1, 2, 3, 4 for the nodes. And again, for the primary, level 1, no evidence of recurrence. Level 2, low suspicion. 2A is superficial. 2B is deep. 3 is high suspicion. 4 is definite recurrence. And same thing for lymph nodes, for neck nodes and the neck. So we have staging for the primary and staging for the nodes. Now we also have terminology. Some people love this, some people hate this, but the idea is that we have some standard verbiage that we're all using to try to standardize things. At my own shop, we had a huge amount of trouble getting people to either use templates or use standard verbiage. And I was also on the RSNA RADLEX committee for the head and neck section years ago, where we tried to make standard head and neck verbiage, standard words. And as you can imagine, trying to get everybody to do the same thing in this world these days is extremely difficult. Now, some people have already done research kind of looking at these cases and these numbers. How effective is this? And that's obviously something we want to do. We want to try to use evidence-based medicine and apply that to all our cases. So they went through 318 scans with 618 target lesions. So about 300 primary and about 300 node cases in those cases. So they graded most of them as NI-RADS 1. So about 85% were NI-RADS 1, 9% were NI-RADS 2, and a minority were NI-RADS 3, only 5%. And then they followed up all these guys for about 2 years and tried to differentiate what the positive rate of disease was on the patients after 2 years. So on the 85% of patients that they graded as NI-RAD 1, when they followed those up, 4% of them had disease within a couple of years later. For the NI-RADS 2 cases, about 17% of them had disease, and for the NI-RADS 3, we were at about 60%. So that makes sense, and that suggests that the system works. If we think about the imaging findings and that staging, those are kind of the findings that we would expect, that the NI-RADS 3, the cases were highly suspicious, they're most likely to show up with disease later on. So who are the NI-RADS patients? These are head and neck cancer patients after definitive treatment with a PET-CT study. So they've already had definitive treatment, whether it's chemo, surgery, radiation, chemo-RADS, whatever combination is, and they have a PET-CT. So that's obviously going to limit the patients that we use. I kind of thought we should be trying to use NI-RADS on everything independent of modality and pathology, but I was voted down. It was very sad. Now, later they did add contrasted CT and MRI to that staging system. But the idea is with NI-RADS patients, it's only head and neck cancer patients, and initially it was just squamous, and it was only after definitive therapy and only if they had a PET-CT study. Now, there aren't that many PET-CT scanners around, so that's obviously going to limit the number of patients who do this. And not everybody's doing PET-CT as frequently as some sites, for example, for us in the US on the East Coast. So when do we use NI-RADS? So they had a system. And this is helpful if you're not familiar with head and neck cancer patients. If I have a patient after they've completed therapy and they're asymptomatic, we can just do a standard PET-CT 3 months after they finish therapy. So after surgery, chemo, radiation, whatever, 3 months after they finish, we're going to get a PET-CT. If that's normal, then 6 months later, and they're still asymptomatic, we're going to get a contrasted CT of the neck and the chest. Again, the chest we include because some patients have distant disease later on. If that study is negative, again, 6 months later, we'll just do a contrasted CT of the neck. And if that study is negative, then 12 months later, we'll get again a CT of the neck and chest. And at some level, if you do have a head and neck cancer patient, if you get to about 7 years out, we usually think about you being cured from that cancer. And if you get another primary, even if it's the same site, we think about that as a second primary because you already have the genetic predisposition to get cancer and you already have the socioeconomic factors that led to you getting that head and neck cancer in the first place. Now, we did add MRI after some arguing. So especially for sinonasal cases, parotid, nasopharyngeal carcinoma, perineural tumor spread, and intracranial spread and orbital spread are easier to see on a contrasted MR, so that was added later. So again, this is kind of a limited population. If it's only squamous cell carcinoma patients, only patients who have completed therapy, and only patients who have a PET CT, because not everybody's got a PET CT scanner that they're religiously doing their follow-up. But if you're not familiar with workup of head and neck cancer post-therapy patients, this is a good baseline system to work, especially if you're not at a big cancer hospital where you may have different therapies and trials that are going on with your patients. So how do we use NI-RADS? So this is the big idea. So again, we have these different levels, 1, 2, 3, and 4. They're nice color-coded. We get more excited the closer to red we get. We did add the level 0. If it's a new baseline study, I don't have prior imaging, I don't have history, I may technically score that as a 0. Obviously, we don't use that very much in this system. But again, we have primary site and the neck are both going to get staged. And we have some imaging findings that we attribute to that. And we have some idea of management, what we recommend based on those imaging findings. So let's go through some cases and look at a green, a yellow, an orange, and a red case for the primary and the neck to see how we actually use this staging. And we could think about starting with the imaging and the staging system or kind of going backwards, and we'll take a look at that. So first, a green case, category 1, no evidence of recurrence. So here's a patient who had a T1 N2C base of tongue squame. So there's a little area here in the base of tongue or the lingual adenoidal tissue with increased uptake. We see it has increased uptake, it has high density, and we see what looks like increased uptake in some pathologic nodes on that side. So in this guy's follow-up, we saw nothing. This looks great, looks like CR, complete response. So I don't see any increased uptake, I don't see any high density. We look for that high density, especially on virgin untreated squames of the upper digestive tract. We don't see any mass effect. Everything looks good here. We don't see any increased uptake. So that's going to be green, category 1, because there's no abnormal soft tissue and no abnormal uptake. That's great. So next is category 2, low suspicion. So here's an axial CT post-contrasted. I've got a big high density mass that's kind of wrapping around that glossotonsillar sulcus, the sulcus we think about between the palatine or fasciotonsil and the base of tongue at that lesion. So usually we see base of tongue going to the tonsil. We don't see as often the tonsil going to the base of tongue, but this is certainly a big issue these days with oropharyngeal HPV positive squames, which have really changed the way we think about squamous cell carcinoma, certainly than when I started 30 years ago. So we have a definite cancer here that's high density wrapping around the sulcus. We see a lot of increased uptake and we see nodes. So this is a T4A, it's a pretty big base of tongue squamous cell carcinoma. So in this guy's follow-up, we had significant decrease in the amount of uptake and it was less uptake. And when we looked at the CT to compare the same area of increased uptake, you don't see high density there. It's actually low density. And it looks kind of like you have an ulcerative crater with low density around it. So that's kind of discordant in a sense. You have increased uptake, but you don't have the high density that we expect to see on the contrasted CT. There's a little bit of fluid in the retropharyngeal space, probably post-radiation change, sympathetic or reactive fluid. So we would grade this the level 2. And if it's superficial, I'm going to say, I don't see any soft tissue here, but there is a little bit of increased uptake and it's superficial. So somebody should go in and look at this. And they looked at it, direct visualization. They weren't very suspicious. And sure enough, when we did the 6-month follow-up, it completely disappeared CR. So that's a good case for a NI-RADS category 2A. So how about orange, category 3, high suspicion. This is a patient at a big maxillary squamous cell carcinoma centered here at the anterior maxilla on this axial T2 with fat set image. When we did this guy's follow-up, Here's a big surgery, so I've done a resection. We sometimes do these big orbital exenterations. We may take part of the maxilla with us, but we do see there was this abnormal soft tissue and a little bit of osseous destruction right there, lateral orbital wall in the surgical bed, and focal area of increased uptake. So we're very suspicious of that. So that's going to be category 3. We've got focal abnormal soft tissue there with osseous destruction and intense FDG uptake. So that's going to be category 3 for the primary site on our follow-up. So how about lymph nodes? Same kind of thing. Here's an axial CT. This guy's after therapy. Looks like post-radiation, maybe a little wet and boggy at that area. Maybe the epiglottis is a little bit thickened. We've lost a lot of our expected fat planes, thickening of the platysma. And we do see a lymph node over here on the side. Maybe it doesn't look that bad. This is 3 months after his therapy. On the more delayed follow-up, 9 months, we see that lymph node definitely got larger at the angle of the mandible and a lot of increased uptake. So we're very suspicious of that. That's high suspicion in a lymph node. So the next staging is going to be 3 NI-RADS on this guy because of an enlarging abnormal node and intense FD uptake. Then lastly, category 4, the red, were definite disease. This is a patient that had a big hypopharyngeal squame, and he had a big lymph node on that side. So that's a T2, depending on its size. We did initial follow-up, and this actually shrunk down on his first follow-up study after chemo-RAD. And then 6 months later, on his more delayed, we had a lot of soft tissue in that area and avid increased uptake. So this is definitely disease. This is definitely recurrence in this patient. So we say that because of the enlarging abnormal soft tissue and the intense FDG uptake at that site. So that's going to be category 4, definite recurrence. So it's the same thing in lymph nodes. This is another different patient who also had a hypopharyngeal squame. After chemoradiation, he had a sore throat. This was a little tiny lymph node that was missed, retropharyngeal. When he came back, this is a definite pathologic lymph node. And he did have increased uptake on his PET CT back at the original study that was actually missed at that time. It's very hard to palpate back there, so it's our job to try to look for these retropharyngeal nodes. So this is going to be a nodal category 4 NI-RADS because we have an enlarged abnormal node with intense FDG uptake. So to finish up, why should we use NI-RADS? Well, it's kind of a nice system. We have these well-defined categories, incomplete, no evidence, low suspicion, high suspicion, and definite. Each of those has well-defined imaging findings and management. Anytime we're guiding management, that's a good thing for us. And again, we can think about this as managing the primary as well as the lymph nodes. So for the primary site, whether it's superficial, deep, or definite, if it's superficial, we think about that enhancement. Is it diffuse and linear? Is it focal or nodular? That's going to recommend management. If it's deep, it may be ill-defined or discrete mass. If it's ill-defined, we can look at the FDG uptake. If there's none, maybe we'll do routine surveillance. If a little bit increased uptake, maybe short-term follow-up. If we definitely see a mass and there's intense uptake, that's going to be level 3. We're going to want to biopsy that. And if it's definitely pathologic, we treat it. So this is a pretty good system if you're looking at postoperative necks and you're not familiar with what to look for and you have a PET CT. And same thing with lymph nodes. When we think about nodes, we could think about no new nodes, residual new or enlarging nodes, or definite abnormality. If there's nothing new, that's level 1, obviously. So you're just going to continue routine surveillance. If there is new, we think about necrosis or extranodal extension. If there's none of that, then we look at the FDG uptake. If it's intense, we're going to biopsy it. If there's no uptake, routine surveillance. And again, if it's a mild to moderate, we may do a follow-up on that patient. If we do see new necrosis, we're probably going to want to stick a needle in that. That's going to be level 3. And it's definitely pathologic. We're going to think about treatment in that patient. So when we think about NI-RADS, hopefully this is saving time for both the radiologist and the referring doc. We like to guide management when we can. Hopefully we're adding confidence and clarity and adding value to our reports. The idea is that we're simplifying communication here, but we're also directing management with our referring docs and assisting with our quality projects, QI, QA, QC, M&M, and providing patient care. Now, I personally had some problems with this. One was the modality limitation. Not everybody's got a PET CT, and not everybody uses it the way that these people do who are doing NI-RADS routinely. I wanted it to be modality independent and pathology independent, but I kind of got shot down on that. And obviously it's a big deal with reader experience. If you're familiar with these cases and know what to look for, that's very different than if you're not comfortable with postoperative cases. And there's things like radiation that may look very complicated with wet and boggy changes. And we know that head and neck recurrence may often look like an abscess. So that's very different than the hypercellular increased density on CT that we look for. And also nuclear medicine. Who's reading the study? Is it the nuclear medicine guys or is it the head and neck guys like a neuroradiologist? As an example of that, this was a case that was read out. This patient had a nasopharyngeal carcinoma. You see it invading the skull base. Maybe it's in both cavernous sinuses. It's in the prepontine cistern back here. They did surgery, resected the lesion, and this is a follow-up. And this was read out as definitely disease, NI-RADS 4, because of this big enhancing lesion. And they said, well, the lesion was originally enhancing. This looks like recurrence. When they looked at the post-op, though, somebody asked me to look at it, and I said, well, actually, this is very bright on the T2 and the ADC. Both of those are rough markers of tumor cellularity. And when we look at the preoperative compared to the postoperative, here on the T2, we see that preoperatively, this was very dark. And on the postoperative follow-up study, this is very bright. So to me, this does not look at all like the original tumor. And both T2 and ADC are rough markers of tumor cellularity. This lesion was initially very dark in the ADC, and your follow-up enhancing tissue was very bright. So I actually changed this kind of from a NI-RADS 4 to a NI-RADS 1. And that's obviously a very different surgery. They were getting ready to sacrifice this patient's carotid and go through it. So who's reading the study is very important. And also nuclear medicine studies. We know there's a lot of false positives and false negatives. This was a study with an obvious necrotic pathologic node that nuclear medicine thought was not pathologic because it did not have increased uptake. So that's kind of a pitfall of nuclear medicine. So that's a review of what is NI-RADS, who are these patients, when do we use it, and how do we use it? And there's good and bad of these different systems, but anytime that we're systematically categorizing something, I think that is something that can help our patients and help us be involved better in patient care. So hopefully I can make it over there in the future, but for the time being, we'll have to go with this. And I thank you very much for your attention.